I am so happy to present to you the next conferencer. It's Dr. Carine Ben Younes-Uzan who's going to talk about the best moment to start a froggy mouth treatment in function of the age of the patient and the treated pathology. So it's an honor to have Carine here. Carine has been amongst us for many years, collaborated with us, and you can see the change of the program from the morning to adults, and she's going to show froggy mouth on the patients, the children who are younger and younger, and more competent, formed and Carine has been trained in Belgium at the university. It seems to me that you first started your career at the University of Brussels, and you're part of the SPR Society. I was. Oh, you're not anymore. No, but you are in the Society, French Society of Pediatric Orthodonty. So thank you very much. And I like your hair. So I'm going to pass the microphone to you, please. Right. So thank you so much, Guillaume, to have passed on the microphone to me. So I'm going to explain in practice the froggy mouth in pediatric orthodoncy. So first of all, I'd like to give a big thank you to Dr. Philus, with whom I have worked during many years in Mer de Pré. He taught me the pediatric orthodonty and helped me develop his teachings to be able to continue even further. You can also see the professor from Fez, and Marie Landru, who is also a member of the this association, EPERO. So when do I use froggy mouth? I think this is quite interesting because I'm going to talk to very practical experience here. I came from the practical area, practical branch, rather from the university. And actually, when do we use it? When we need lingual re-education. So rehabilitation, when you have a malocclusion. So to be able to make it, to have success, you need to put yourself in a position of success. So here we have some people come to me and say, hey, it doesn't work. I've tried it. It doesn't work. So you've really got to put them into favorable conditions to put them into a logic of success. So first thing is that you should not have any locks, because if you've got a lock, then you are not in a favorable anatomical context. So it depends upon the deformation. So the malocclusion has to be blocking. We have to take out the blockage, so we don't have any blocks. What is a blocking occlusion? These are all cross-bite maxillary hypoplasia that we can see on the first picture. It's clear that if we're going to place the froggy mouth onto this kind of mouth, it's not going to work because we're not going to re-educate the tongue in the same way. And here we would have a Brosby symptom, like with a scissor bite. We have a total occlusion, no hope of improvement with froggy mouth. But if we have a complete when I say we don't have any success, you really have to understand. If we have a blockage, I'm saying absolutely, only in that case. So here if we have a complete overbite, which means that if a child hits the tongue with the palate all the time to the palate, then we need to re-educate the tongue so that it doesn't always hit the palate. So my form of treatment depends upon the type of patients. I only work with children. If we are with children who are in the age of toddlers, so that's very good because they don't have any occlusal blocking yet, since they still have their milk teeth. So when you reach the orthodontic age, that's starting from the age of 4.5, then you can start using braces, tools to have a better results. So here we have, here from my screen, right. So what you can see here is a picture that I really like, because it really shows the seaside. I enjoy the seaside, and you know the tongue with the teeth is like the sea with the rocks. When I was talking about these blocks, these teeth blocks is if we have these blockages, then we have these traumatizing occlusions. And if we have an if we have problems with the tongue movement, we want to use froggy mouth, but you've got to be careful that the child does not suck its thumb, nor uses the bottle, nor uses the dummy or anything, because if the child does, we're not going to get any results with froggy mouth. So there are two issues how you can re-educate the language, either by re-educating the tongue, or you re-educate the teeth. So here I closed it. So with the two, so here we still bottled the child. So the child was still drinking from the bottle, and then you can see, because you see more and more babies who still continue to use to use the bottle, or to use the a bottle with a nipple on it. So this is a child that still has that, and when it stops, it's the ideal moment to take the froggy mouth into consideration. And then there is still the if what point of time can you start use it? So if the baby is no longer bottle fed, so the beginning of the treatment, so a child who's about 4.5, 5 years old, that's an age that I really enjoy treating. He has a class 2, and he stopped sucking his thumb, and he used to suck his thumb. So why we should use froggy mouth is because we can act on the maxillary, and as we're going to re-educate the tongue, we're going to favorize the dentary proxic slow movement. So when we use this, we have an enlargement of the jaw, which enlarges itself spontaneously. At the beginning of the treatment, I was thinking of putting a tool to make the mandible grow, but I didn't have time, so we enlarged the top part, we put a froggy mouth, and the rehabilitation did the rest. So with the dentistry, this made the jaw grow and advance. So as I said before, when we start a treatment and we have a baby that still sucks the either their thumb, or still uses the feeding bottle, still uses feeding bottle, then we cannot start the treatment. So here an improvement, and the mandibular growth is absolutely visible. And when a child comes sucking their thumb, then we can make a diagnostic which is differentiated to a usual suction, which is habituary. Many babies have been sucking their thumbs since their babyhood, and these who really need it, most of them just stop sucking their thumb at a certain age. And if we have a sudden stop of a thumb sucking, either you get a brace, because it's a good moment, because it's new and there are new sensations, so that the child can integrate a new position of their tongue. And with a froggy mouth, this is going to help us into this direction. Moreover, once we don't see the tongue that is being interposed between the various arches, then we're going to have a circular movement in the mouth, so tooth against tooth, and even against an artificial palate. We have we're promoting this section. So here we have a child who had a brother in class 2. So we've got a good, nice maxillary area, good mandible. He sucks his thumb. We give him here on the pad. I actually thought here we can start by giving him a brace so that he stops sucking his thumb, re-educate him, and then we put an activator. He's already 7, and that's what I was planning on doing, and there we go. So I give him a palate, and strangely enough the mandible is coming forward, the maxillary is getting larger, and it's very good, and the mandible moves forward. Another case. Here I'm giving you, showing you many clinical cases. Another case where we can see it's the same. We have a little patient who has her teeth which go a bit forward. You see that her mouth is totally pink. We see the X-rays, and we see the maxillary volume. We start making an expansion coupled to a rehabilitation, and everything comes back into place magically and quietly and easily. Another case of a child. So here we have a hyperdivergent. These are cases of hyperdivergence which are dysfunctional due to many cases. And these are totally dysfunctional, where the muscular structure is not clear. And here I made a first treatment where I opened the mouth, and here it came back this way with this X-ray, and we started again with froggy mouth. So I think here the froggy mouth might have been a bit big. Maybe I can use a smaller one. Then we can see a repositioning of the incisives. At the same time, we have an expansion where everything comes back into place, and everybody is happy. Then at another point in time to use the froggy mouth, since my logic is always to try and use it to get a good result. So if we have the contrary articulation, then we should not place a froggy mouth right from scratch, because even a froggy mouth, when you start it, you have a traumatizing occlusion, and that can never establish itself. So there we start putting a brace that's going to unbuckle the teeth. So with this appliance, you can it allows you for an expansion of unblocking of the teeth, and if you have a maxillary effect without involving the mandible. That's the first part. So this is the first part where we want to enlarge the upper jaw without moving the part. And then once we put the upper jaw, I use the froggy mouth again to allow a rehabilitation of the mouth, because I'm going to take out the calc which is in between the teeth, which I'm going to show in another patient, so that the teeth can box themselves into position. Then now with COVID, ever since COVID, and this mask wearing, it is quite difficult to explain what re-educational exercises you need to do. That when I was with Patrick Phillips, because you have to keep your mask on and you can't show which mouth movements the children should make, and it's a lot easier with a froggy mouth to practice it using a mask. I've got lots and lots of examples. It's always the same procedure. We've got here a cross lateral, so these are clinical cases, and here we have the interposed area in the teeth, and once this is passed through the lower part, we can continue, and at that point we can use the froggy mouth. And we see that this isn't finished. The treatment isn't finished, but slowly we are getting a horizontalization of the mouth, and we have the mandible which has changed, and she continues to have a unilateral mastication. So now we can see that the froggy mouth will allow to encourage the proper reception of the mouth and avoid the interpositioning of the tongue. So there we are. And then we treat this with a high elevation of the lips. The teeth go up, and there we have an occlusion, and furthermore, then I started to make an axillary maxillation without elevation, because here it is very interesting to use you can see that she really needs it in this case. And why can I start? Because if you see that the canines are badly orientated, and the fact of enlarging with a rehabilitation with a good mouth positioning in certain cases, then you can see the canines coming back into place, and you see her face is a lot more harmonious. She breathes better via her nose just by looking at her face. So you can see the progress. So another patient who had a traumatism on the 51st, and we had then an abscess, a displacement of the 11th germ. So here you can really see an ectrothesis of the arcades, of the arches, sorry. And then we have the canines that have an overlapping, and you shouldn't leave it that way. Otherwise, we have some root which is getting stuck. We have to intervene. And this is why we have an enlargement to re-educate the tooth. So we have a palatina and some expansion because these teeth were very pulled back, and this is 6 months of treatment with the expansion and rehabilitation. At another point in time where the froggy mouth and the rehabilitation is very interesting is also to stabilize the results that we have here. You can use it at the same time. You can use a trough or a contention method, or with the very small children. I changed this 5 minutes ago because I thought I would like to illustrate this. So this was a little girl who had a family issue, so that wasn't really a very clear case. But when you're used to make these treatments, then you can see that the smaller cases are sometimes far more difficult than the bigger cases, with a very nice closure. So here we put it back on, and you see the results. So I'm going to continue. This is very interesting. So all these black areas that we see, these gaps, we know that this is the tongue. The pink, it's the tongue pushing upon the teeth. And what's interesting here is at that point, these are pictures that we see. We put on the froggy mouth because Guillaume asked me to talk, and we had this on the patients to present, and we can here see that we have an improvement of the with the two last pictures, the series. We only have 2 weeks in between, and you see all the beneficiaries of this, the position of the tongue that we have here. So thank you for your attention, and I would also like to add that I have no interest conflict, and it's only out of friendship for Guillaume because I think his system is really good, and this is why I talked about it. I was saying that I thank you twice, Carine, on the first of all, because you came and presented these wonderful strategies and these nice cases, and secondly, because you accepted to come and talk these Froggy Days, because you generally don't do these types of events online with these kind of commercial societies, and that's why I'm extremely happy that you accepted my invitation. Especially with all the years of collaboration that we have. And so I'm particularly grateful to be with you because we shared many nice days in the orthodontic pediatric societies. So I just wanted to mention that in the last 2 conferences that you made in the pediatric orthodonty, you developed this freehand developments, and you can find them on YouTube with Emmanuel Heres. Same as with the previous speakers. We're going to go straight on to Facebook with the different questions and answers, but we're going to explain everything so that you can answer to all the questions that might have direct questions according to the conference, whether it's now or it's on replay. So as I'd like to already say, Karen's also going to be part of all the conference that are going to be part here, and we were able to receive from the platform an ecosystem that you were able to discover in the next 3 months. So you will have 3 months of time to look again at these conferences on replay and ask all your questions as you go along. Carine, thank you so much. And there are no questions. No, for the moment, we have no questions. Right, so I think that was very clear then, what I described. If there are no questions. Yes. So I got 4 people who asked, how did you do your last mandibular expansion? And then we had the discussion. Okay, so what was it? So the principle is that I use a lot of these boxes on the children, but when there's a supraocclusion to have lateral movements, I use them because the movement is the stimulation of the mastication, which goes very well with the rehabilitation, because the rehabilitation of the tongue is more or less the same. And when you've got class 3 or infra occlusions, then I use posterior occlusion for the same reasons. And I use the froggy mouth at that point where I know that it's useful, because if you take a child and give them a brace during 3 years, you should not annoy them for long. You have to be persistent, and you have to intervene at the right point in time and expect efforts from them. They're going to be fractious right from the beginning. There's another question, and I see here the various universities, research centers, so a big thank you to that as well. So how much time in terms of months this use of froggy mouth is going to be used? If we think of a term of 15 minutes per day, it depends how much I will put it on. If I put it on at the beginning of the treatment, then I see them again 1 week later to see if they are okay, and that's extremely important. I learned this with your father, and that's very important, because if we have an issue with the braces, we have to apprehend it on time, and then we can use it, and then we see them 6 months later, and according to that, I have not normalized it. It's a feeling, and I never like things to take too long. I let them put on during 6 weeks the brace, and then a bit less, and then as soon as I take it off, I start again. Thank you. So I'm going to pass the next question. So the spontaneous advancement of this mandible is not always the case after an expansion of the maxilla. Is that case? True, absolutely. Otherwise it would be too simple. But of course there are some cases where we do have this, and I showed this to you, and it was the case from time to time. It's quite good to have a re-education, and from the moment where we establish a dental and a lingual mandible, especially with the little ones. I'm not talking with adults, because with adults it's impossible, but with the smaller, then sometimes the things go by themselves. Okay, so we give ourselves a supplementary chance. Absolutely. And it goes in the sense of the treatment. We don't waste any time, and then we give them a brace to solve the problem. And they then resolve even more problems than the others. Thank you very much for this very complete answer. There are going to be some more questions that you will see on Facebook. As said, every person who has a question in the coming months can ask the questions and obtain an answer. so that maybe you will then have the time to answer to all the people who have questions in the next 3 months. I'm sure there are going to be quite a few questions that are going to be asked to you. So everybody who's looking at me in replay, please don't hesitate to go into the Facebook group, look for the communication of Dr. Carine Ben Younes-Uzan, and then you can ask all your questions and give your comments, and Carine will answer all your questions to you. Thank you so much, and thank you for your attention.